Okay, welcome everyone. My name is Joanna Lewis. I'm the director of the Science, Technology, and International Affairs program and a professor at Georgetown School of Foreign Service. And I'm very pleased to welcome you all to the STIA program's annual Maloy Distinguished Lecture in Global Health. Global Health is one of the main pillars of the STIA program, which is led by two of our core faculty members, Emily Mendenhall and Rebecca Katz. And our STIA Global Health faculty have been conducting cutting-edge research throughout the COVID-19 pandemic to help inform us about the impacts of the virus on the United States and around the world, and to help policymakers find solutions. Many of our STIA students are involved in this research as well, and we are thrilled to have one of our STIA senior honors students, Maida Danuka, joining us on the panel this afternoon. The Maloy Lecture in Global Health is supported by a generous gift from the Maloy Family Fund. Since 1999, Paul and Catherine Maloy have been supporting health-related projects and events in the STIA program, and we're very grateful for their family's support. Today's panel was organized by Professor Emily Mendenhall. Emily is a Provost Distinguished Associate Professor here in the STIA program, and as a medical anthropologist, Professor Mendenhall has been undertaking ethnographic work around COVID-19 in rural America, including in her hometown in Iowa, as well as in Johannesburg, South Africa, where much of her research is focused. Professor Mendenhall's most recent book, Rethinking Diabetes, Entanglements with Trauma, Poverty, and HIV, was published by Cornell University Press in 2019, and she is now the co-editor-in-chief of a new journal of social science and medicine focused on mental health. Her work has been supported by NIH and NSF, and she holds a bachelor's degree from Davidson, a master's in public health from Emory, and a PhD in anthropology from Northwestern. And today, Professor Mendenhall will be leading our panelists in what I'm sure will be a very interesting discussion. After the discussion, we will be asking the panelists to respond to questions from the audience. So feel free to submit your questions at the Q&A link at the bottom of Zoom throughout the event. So thank you all again for joining us today. And I'll now hand it over to Emily to tell you more about today's program.
Thank you everyone for joining us here in this virtual space. It's a bit different than usual when being Copley Lounge or somewhere together gathered and sharing this space together and then followed by an intimate dinner. But we're lucky to have this time to see each other even though it's virtual. This year we're hosting the Maloy Distinguished Lecture a bit differently than in the past. Each year the Science, Technology, and International Affairs or STIA program host a distinguished lecture about global health, and we have an impressive list of lecturers. Last year, we hosted Dr. Sarah Bennett, an expert in health systems, and the year before, we hosted Dr. Akin Obayomi, the Minister of Health for Lagos State in Nigeria. 3 years ago, we hosted Helene Gale, a leader in global health development. The year before, we welcomed Dr. Vikram Patel, a true visionary who's transformed the movement for global mental health. Our esteemed lecturers include Editor-in-Chief of the medical journal, The Lancet, Sir Richard Horton, as well as the famous Dr. Anthony Fauci and award-winning journalist Laurie Garrett. These enriching lectures have been made possible by the generosity and vision of Paul and Catherine Maloy, who Professor Lewis introduced. Paul Maloy is a 1968 graduate of the School of Foreign Service, and Catherine Fowler Maloy is a 1968 graduate of the School of Nursing and Health Studies. And each year we try to represent these backgrounds of our generous donors who are incredibly kind and continue to support and engage us. And they've both been active in Georgetown alumni relations for many years. So today we welcome an impressive panel working at different levels of the COVID-19 response who is connected to STIA. Instead of this singular lecture, as we've done in the past, we host our well-known and beloved STIA faculty member, a leader in global health security, Dr. Rebecca Katz, as well as several alums who I'll introduce in a minute, who've rolled up their sleeves and dug deep into understanding and responding to COVID-19 in the United States and around the world. We are so lucky. And of course, this is just a handful of STIA alum, faculty and friends who are working on COVID-19. So many of us are. And so we're very lucky that you all made time for us today. So first, let me introduce Dr. Rebecca Katz, whose leadership extends well beyond Georgetown. Dr. Katz has pioneered the field of global health security. She hosted the field's first international conference in 2019, developed essential tools for planning for and responding to pandemics, served as an advisor in the State Department for 15 years, advised the Biden administration, and now is back at the Department of State as an advisor to Secretary Blinken. We are grateful she carved out some time for us today, and I'll be directing my first question to her. But first, let me introduce our other panelists. Dr. Michael Capello is a professor at the Yale School of Medicine who studied medicine at Georgetown. As an infectious disease specialist, he is active in responding to COVID-19 as a physician in Connecticut, but he's also a global health practitioner, and his work was stalled with collaborators in Ghana and faced some difficulties amidst these global collaborative teams when the pandemic hit. And we're hoping he'll speak a little bit about working in global health teams today. And Mayan Jaffe, also a STIA alum, graduated. She was one of my first STIA students, which I'm very proud of, with a master's degree in public health from Columbia. She serves as a senior project manager in the office of the Deputy Executive Director of New York City's COVID-19 Test and Trace Corps. And the work has brought her to the front lines of the COVID-19 response in the most affected urban contexts in the United States. And finally, my STIA honors student, Maida Danuka, is a senior in the STIA program. Maida responded to the COVID-19 crisis in her community of Redding, California, by conducting an ethnographic study around people's perceptions and experiences around the virus. And this is the topic of her honors thesis, and she'll share some of those insights with us today. So it's a real honor to welcome all of you to this virtual space. And I'm not going to say anything else. I'm just going to jump into our first question. So before we get started, some ground rules. I have a specific question for each of our wonderful panelists, which I will direct and start from. But if you have additional questions, please put them in the chat, and I will ask them as they come in, as long as they're building on our community conversation here today. But I will direct the first question from the chat after our last panelist has had their first question. So please stay with us, engage, send your questions. We're very excited to have you here. So first, let me direct the first question to Dr. Katz. So Rebecca, we know that you're incredibly involved in the COVID-19 response and essentially have slept very little over the past year. I remember when you first started worrying that coronavirus was going to be a global challenge in January of 2020. But we know that this pandemic is not a surprise. You've been talking about a global viral threat for years. Can you describe what was the biggest surprise, besides the dog, about working on a COVID response in America? And what was the greatest challenge you faced over the last year when working on global threats?
So I will start with the dog. I mean, the joke is that, so first, thank you. Thank you for having me, and so delighted to be here with everybody. And it's nice to be with the STIA family right now. So as you mentioned, I've spent the better part of 20 years working on pandemic preparedness. And I say it is a joke that, the biggest surprise to me over the last 12 months has been that I became a dog person, in part because we predicted a pandemic. We predicted, with most of the community was pretty confident that if there was going to be a pandemic, it was going to be either a novel coronavirus or a novel influenza strain. All the parts of global governance of disease that failed were predictable. So I say as a joke about the dog, but in some ways it's actually true. I think your questions about what has been a surprise. I think even when things are predictable, there's a lot about this past year that's been very surreal. But that being said, if I was going to list off just a few of the things that I think were notable, that are going to require lots of time and energy to go back and figure out why all of this happened and how do we fix it. But the fact that at least domestically and internationally, but certainly domestically, we literally had a playbook for how to respond to this type of biological threat, and it was thrown out. Nobody even opened it. I think the surprise of having a federal government that didn't own the problem, the fact that the strategic national stockpile had been kind of almost left bare, that we didn't immediately use every federal asset available to us, and that the states and locals were basically told you're on your own, including on your own for procurement and things that the state and locals had really never prepared to have to do. The politicization of public health measures like masks, leaving the World Health Organization in the middle of a pandemic. And I think the other thing I would say is that one of the things that was I think really challenging and also really surprising was that there wasn't a trusted single source of information. And so where many of us in the past would have looked to CDC, we couldn't get the data that we wanted to make real-time decision-making. So I think because of all this, I think those of us on this panel, as well as every public health professional in the country, ended up having to step up to be able to, not only in terms of maybe research that was already ongoing, but research, advising from governors to mayors to every private industry to our universities. So I think that was all a challenge. On my own end, our research team quadrupled in size. So we suddenly had we were doing a lot more work all the time with a lot more people, which was really exciting. I think at the same time, we were seeing shifts within our own institution and the way that we work. And then also I would say for me, pandemic preparedness has always been political. It was never partisan. And so having to see that this had become a partisan thing, which actually led me to become involved in a campaign, in a transition, in a more political partisan process that I had never been involved in before. So that's my year in a nutshell.
Well, thank you. Let me direct my next question to Michael. We know that coronavirus upended many global collaborations, and you mentioned that your teams in Ghana faced many challenges because of COVID-19. Can you describe for us how you manage those partnerships while responding to the local outbreak?
Yeah, sure. Thank you, Emily, and fellow panelists. I'd like to say thank you to the Maloy family as well, of course, especially Christine Maloy Jacobs and Nick Jacobs for helping to facilitate this invitation. I don't think there's any question that the impact of COVID-19 on global health research has been pretty dramatic, not just in sub-Saharan Africa, but also pretty much across the global South, where a lot of these relationships and programs have been established. In our case, we started in 2007 an ongoing collaborative research program that was a sort of an equal partnership with colleagues at the University of Ghana, but also involved parts of the Ghana Health Service, NGOs, et cetera. And the focus of this research has really been on the understanding the impact of parasitic diseases on child health, development, nutrition, et cetera. And so at the start of the pandemic, going back to February, March of last year, we were literally in the middle of two separate NIH-funded studies, one of which was looking at creating the first kind of map of deworming drug effectiveness across Ghana, which required a multi-site project. And then a second one focused on trying to identify potential genetic mutations in these parasites that confer resistance to some of these drugs. And so we had these very active programs that were ongoing. And then essentially in around April, everything ground to a halt. So obviously in the US, we were pretty much shut down, but in Ghana and a number of countries in sub-Saharan Africa, they also shut down, kind of waiting for this wave of infections to hit. We closed our lab for the first time in 25 years. Our colleagues in Ghana had to recall all of the field teams that were sort of scattered about. Everybody sort of came back home, and interestingly, towards the end of last year, as things began to open up in Ghana, certainly that first wave not being as dramatic, I think, as had been anticipated. We sort of went back out into the field. And then unfortunately, at the end of the year and the beginning of this year, they were really hit with this next wave of infections. And I have to say, whether it's related to some of these variants, in particular the South Africa variant, or not is unclear. But this current wave that my colleagues are experiencing in Ghana has been much more dramatic, many more hospitalizations, deaths. Even a couple of my colleagues and friends who are working there have been infected and gotten ill. So it really pretty much resulted in a lost year in many ways. And although that sort of loss of research progress is regrettable, I think from our perspective anyway, much, if not most, of the focus of what we do is really built on this bidirectional training and exchange of students and trainees between our institutions in Ghana and here at Yale. And that had sort of gained a lot of momentum. We were building this sort of network of young researchers. And I'm really probably more concerned with the impact that this has had, this interruption of progress has had kind of on some of the training aspects of certainly what we've done and many of my colleagues who do similar work around the world. Because, as these governments are now going to have to deal with the economic impact of the pandemic and try to sort of, recover and reinvigorate their economies, I'm very concerned about the status of training and educational opportunities for people who are interested in pursuing careers in public health. And so I do think that's going to be sort of the legacy of this, will really be a test of how well we can support our colleagues in the Global South to be able to recover this from the impact it's had on not just research, but education and training. So I got to say, on a positive side, I think that these circumstances, they allowed us to develop a more active kind of distance learning model and partnership. Both places can take advantage of the technology that they have. We've increased the frequency of our online meetings. We've, as my colleagues in academia can also appreciate, tried to address the backlog of manuscripts and abstracts that we hadn't really had time to finalize and push forward, and that's been helpful. And ultimately, I think with the arrival of vaccines in Ghana just this past week, we're optimistic, in fact, that we'll be able to resume our programs, begin again to bring students from Ghana here to Yale, and send our students and trainees there as well. So it remains to be seen, but I think that our experience has been very similar to many others working in global health, and I think it's going to be a great test to see how, if and how and when we're able to recover.
Excellent, thank you. Now, Mayan, it must be interesting to live through and work on social and epidemiological aspects of COVID-19 in New York City. What are the biggest lessons you and your team have learned, or what's the biggest challenge, and how might that influence city level planning? And I know you're going to want to talk a little bit about your work with migrant workers and immigrant populations in New York City. And I'd like to emphasize, especially for our students, how you can take a global perspective and really think about local inequities and what that looks like and how people experience illness differently.
Sure. Okay, it's a lot to tackle. I'll start with a quick thank you. It's such a privilege to be here. This was an event that I so enjoyed as an undergraduate. And I think for those of us who are kind of stuck in the muck of working on COVID every day, it's not every day that we get to kind of close our work computers and take a step back and really reflect in community with other folks who are doing this work, and to take questions and just to kind of process it together. So really happy to be here doing that with all of you. I think before I talk about kind of what I've learned, I'll just give a super quick summary of what the New York City COVID response looks like right now. So I work for the Test and Trace Corps, which sounds simple, testing and tracing, but it actually has a few different programs within it. We have a large community-based testing program, both with brick and mortar sites, as well as mobile vehicles that we deploy to different parts of the city to do testing. We have a really robust contact tracing program with over 4,000 tracers. And then we also have what we call our take care pillar. So we have a whole kind of branch of our operation that's devoted to helping people to get safely into hotels where they can safely isolate if they live in a crowded apartment away from their family and get connected to other resources as well. And then finally, one of the other really exciting parts of our program is our really massive street-based outreach team. So we have canvassers all over the city, talking to folks, distributing PPE, myth busting, answering questions, and just kind of being a force for good when it comes to COVID. I think for me, kind of taking on this work, one of the biggest things that I've learned is that this has been a paradigm shift, at least in New York City, in the way that we think about how government provides health resources to its citizens and to its non-citizens. I think in the global South, in low and middle income countries, we often talk about community health workers as a common solution for many health disparities and issues that people have when it comes to accessing healthcare. But what we've kind of built sort of by accident here is a massive community health workforce here in New York City, which feels like a radical paradigm shift. And I can share just a couple of examples. So our contact tracers, sounds kind of boring. Somebody calls you, they ask for your contacts, they tell you have COVID, they tell you to stay home. But our tracers do so much more than that. They will literally come to your door and connect you to free food. They will connect you to mental health services, to affordable health care. They'll support you to get paid sick leave if your employer is not being supportive to you in that way. They will literally find somebody to, and this is a real program, they will find somebody to come and walk your dog for you if you are stuck at home isolating and are worried about having somebody to take your dog outside. So it's just kind of this really radically different way of thinking about community care and thinking about community health work. And I think, one of the other things that I'll share about what this workforce accomplishes is that I've heard the story multiple times from tracers who I've talked to that sometimes they'll get on the phone with somebody who is actively in an emergency situation and they live alone, and for whatever reason, either they're concerned about their immigration status or their ability to pay for care, or in their heart, they just don't believe that they deserve or need care. And the contact tracer will call 911 and will sit on the other line on the phone with this person in their home, trying to kind of help them breathe and sitting with them until somebody can come and take them to care. And I think those kinds of experiences, for all the stereotypes about New Yorkers being rude and not caring for each other, I think those kinds of experiences are a really radically different way of thinking about how government can care for people, and something I hope outlives this crisis as well.
Excellent, thank you. So we've been at the global political level, we've been looking at global health partnerships, we've looked at big cities, and now we're going to rural California. So Maida, returning to your hometown was a surprise when so few people took coronavirus seriously. What do you think shaped the reactions of people in Reading who were largely resisting public health measures? And have people's perceptions changed over the course of the pandemic?
Thank you so much for having me on this lecture, first of all. And thank you for asking me that question. So I think probably the most dominant factor in Reading's reaction from what I saw was our town was really hit hard by the economic downturn after COVID and the following restrictions. Because it's a rural area, we didn't really see a lot of cases until much later in the year. They started spiking a little more in November. But before that, we had maybe 10 cases a day, if that. But I can say that a lot of small businesses have struggled. I know probably half of the local restaurants, over half, have closed now. And a lot of big box businesses or larger scale businesses have kind of encroached in. So I think that was one of the really big factors. People felt like they didn't see the necessity for coronavirus prevention measures. And and they only saw a lot of the negative effects from it without getting any support from it. A lot of people struggled to get PPP loans, to get on unemployment in time and things like that. I think since cases have risen, people may have started taking it a little more seriously, but I mean, I went back home to actually get vaccinated recently, and people still don't really wear masks. A lot of people, I think, have gotten really burnt out because they were really scared at the beginning of the pandemic, and it didn't materialize exactly as they thought. So I think for a lot of people at Reading, life has gone back to normal in a lot of ways, which doesn't mean that it hasn't suffered tremendously from the disease itself. So it's been really interesting to be studying it. Obviously, another really big factor. Well, I talk a lot in my essay about this idea of rugged individualism in a lot of rural areas in America. Basically, the idea that we embody some frontier culture where everyone is independent, everyone can make their own living off the land, and they don't need any help from the government, from institutions, from any outsiders. I think that was really prevalent in Reading. And that did contribute to the idea that we didn't need anyone else. People felt that we'd survived. We had a bout of recent fires the past 2 years and then again this year. So a lot of people felt we made it through the fires. Why should we worry about a virus? Or we made it through this economic hardship. So why should we worry about this? I think that was a really, really big factor. And something we can't ignore is that I think 60 to 70% of Reading voted for Donald Trump in this last election as well. And they were dependent on certain charismatic leaders as their sources of information, but they didn't trust the CDC, for example. They didn't trust a lot of news sources. And so I think they relied on one source that was telling them kind of different information. I'm sorry, I had one more thing to say, but it kind of slipped my mind. There's a lot. I've obviously been thinking about it a lot this past year because these are people I've grown up with who I've seen doing some really crazy things that I would never expect. But I think there's overall a sense in a lot of rural areas around America, not just in Reading. I think it's more amplified there because it's a conservative area in a liberal state. But I think a lot of people feel very ignored by policies that are mainly oriented towards urban areas. And a lot of them even understand it. What I heard a lot throughout my interviews were, I understand why COVID policies are focused on areas like LA or the Bay Area, but it doesn't work for us here. We're different and they don't understand that. So I think there's that feeling that they think that they should be treated differently than urban areas as well.
Thank you. So I'm actually going to shift to one of the question in the Q&A questions, and I'm going to actually address it to two. It's to Michael, but I'm going to address it to Michael and Mayan. So I'll read the question, which you can all see. You mentioned that your lab is shut down and that research has been more or less suspended for a year. Looking both at your work and at research across the globe, what are the long-term impacts of this break in work? So should we be concerned about a research gap that will or has stalled critical research? And if so, what is the impact more broadly of this gap on global public health? And I want to have you answer this first, please, Michael, but I want to piggyback it onto a question for Mayan so she can start thinking about her answer, because I think it's important to think about what this moment means in the world. And one of the things that's critical, so this sounds like a kind of intense kind of time in global health, which could be, rupture or rebirth. But also Mayan is talking about this really robust community health worker system, which we've seen again and again and again in crises or, infectious disease programs, vertical programs. Will this stay? So I was wondering if you could talk a little bit about the standing power of these systems that are being built. So Michael first.
Sure, yeah. So in answer to the question, certainly there is going to be a sort of a gap, as I said, kind of a lost year. It may end up being closer to 2 years. Many of these projects that require sort of international collaboration, they can't just be stopped and started on a dime. There's a run-up period that's required. So I do think there will be a gap. Interestingly, the other thing I would say is that for everyone not doing COVID-19 related research, this has had an impact. So I think that regardless, it's not just sort of infectious diseases, but there are similar programs and projects both in the U.S. but also internationally that were shut down, and so it's going to be a universal phenomenon. Interestingly, it reminds me a bit of what happened after 9/11 with the sort of the anthrax and bioterrorism moment, if you will. There was a lot of funding put into addressing those concerns very urgently. And in many ways, it crowded out research that wasn't related to biodefense and bioterrorism. And I've already seen some of my colleagues here at Yale who've really quite adroitly shifted their focus into COVID-19. The opportunity cost of that, of course, is that they're not working on the important things that they were working on before this. So I have heard some talk of a kind of a package to the NIH that would provide kind of an additional bolus of funding, I think, to across the board to support, I think, programs and projects that were hindered by this. I think that something like that would be very important. I'm not convinced that much of what came out of the bioterrorism research in the early 2000s was actually all that useful moving forward. So I'd like to see us, as we get over this hump of COVID-19, kind of redistribute and make sure that other areas of research are getting the support that they need.
So before we shift to Mayan's question, I actually am going to let Rebecca respond to that, who's worked on bioterrorism for a really long time. Do you want to add to that?
Oh, I mean, I just say that I think that I don't disagree that in some respect. I think to your point, in 2001, a tremendous amount of money was thrown at a problem without a lot of deep thought about where that money was going and why and how. I think it is in some ways inevitable. We're literally in the middle of a pandemic. It's a thing that is taking over, and it is requiring every smart person in the world to think about how they apply their knowledge to this problem. And I think for that, the entire field will be stronger. But to your point, we've also seen 25 years of loss in every other global health indicator and all the research that is going on. So we're going to have these were all issues that were important, that are important, and we're going to have to figure out what the right balance is going forward. I imagine that there will be more dollars in coronavirus research than there had been before. I imagine that there will be more investments in technologies for diagnostics and therapeutics and other medical countermeasures, with maybe more emphasis on actually building that manufacturing capacity out. I imagine that there will be more interest, I hope, in the public health field. And particularly, we're already seeing the interest in infectious disease from the clinical side. So I think the question is, how do we do it all? You never can, right? So something's going to fall along the way. But I think there is a deep recognition that I think it's maybe not as pronounced at least in the policy community thinking about research and basic scientific research, but certainly in the impacts of the pandemic on maternal and child health, on HIV, on malaria, like all the other programs. So I don't know, we'll see. But there's, as we all know, there's also a bit of a folks like to fund, I don't want to call it a knee-jerk reaction, but there's often that it's hard to fund with a long-term outlook. So we'll see what that looks like as we start to come out of the pandemic and reestablish the critical work that was happening before.
And I think that, I know Mayan's going to go, but I think that we answered a little bit the need for public policy. And I think in the STIA program, we emphasize so much how important it is to know and think about the science and technology that are, imbued in politics. So, how do politics shape what we do and how we think about health and equity and innovation and possibility? It's things we talk about every day in our classes that Rebecca and I teach. So I think it's a great question, but also, such a critical example of why STIA matters. Maya?
Sure. So I think I can tackle this in kind of two ways. I want to talk a little bit about the research piece, and I don't want to be like Pollyannish about it. I think a lot has been neglected over the last year in the name of focusing on COVID. But on a more optimistic note, what I've seen in my world is an explosive amount of attention to things like social determinants of health, to kind of interrogating this idea of comorbidity and where it comes from, and thinking about structural racism and marginalization and how people kind of are organized socially and how that affects, disease outcomes with something like COVID. And I can share just kind of a quick example of some of the stuff that's been emerging in our work. I think one of the biggest challenges always is dealing with imperfect data, especially when it comes to trying to understand the human experience. And I think we often, when we look at COVID data, are stuck with these very kind of crude categories of looking at people, especially when it comes to race or ethnicity, white, Black, Asian, Latino. And it can mask a lot of hidden nuances and inequities within that. And through this work, we've been able to kind of uncover some of that stuff. So taking a look at some of the qualitative information that's coming through to contact tracers to see, how do people actually identify themselves? Do they check a neat box and that's that? Or are there other ways that people talk about their identity? And one thing that happened that we found kind of sifting through that qualitative data was folks, many people identified in lots of different ways within the umbrella category of Asian as Bengali or Bangladeshi in some capacity. And it was something that regular kind of data sets about public health for a long time in this area have kind of missed and totally masked. And this has been a community that's been really suffering. And kind of through that new way of researching and thinking about how do people define themselves, we were able to run some additional analyses and see actually folks who fall into this kind of larger and different identity group of Bengali or Bangladeshi were getting tested at much slower rates than other groups. And that kind of information allowed us to take a totally different tack when it came to outreach and communications, having contact tracers talk to Bengali media outlets actually based in Bangladesh, not just based in New York, to say, we see you, the government sees you, and this data, the way that we interact with this data is changing, and the questions that we ask are changing, and the services that we're going to provide to you are going to be based on what you tell us that you need. So I have a lot of optimism there when it comes to kind of the future of global health and public health research. Of course, this past year has been a hard one. But I will also say, thinking about the longevity of some of this work, when it comes to long COVID or the aftermath of COVID, especially for people who have other chronic conditions, there's kind of a growing consensus around this concept of aftercare and building out systems, centers of excellence, as well as connections to care and resources for people who are dealing with both the health and social ramifications long-term of this virus. So I think, even once we move beyond this immediate crisis, that's kind of the future of where I see this work going.
That's exciting. That's the potential is exciting, and we'll see what kind of what happens. One of the things I think a little bit about when we're talking about responding to the infection and responding about to this kind of acute crisis is what happens to these long-standing crises. So I work a lot on diabetes and the intersection between trauma or infection and diabetes, and how there's so little money given to non-communicable diseases or diseases that are metabolic and experienced and have a lot of a long life. So, you know, how will the money shift? Where will it fall? This brings me to another question. And Zane, I think that Mayan answered your question, so I'm going to continue. But I want to move a little bit to talk with the panelists a bit about vaccines. You know, obviously, I actually asked everyone on the panel who's been vaccinated. Everyone has but me. I'm so pleased that you're all getting vaccines. And everyone, when it's your turn, please do get vaccinated. And I'm waiting patiently. Probably I'll wait 2 or 3 more months. Well, let's see. But we will all get there, and it's very exciting. But what does vaccine equity mean in the United States? What does vaccine equity mean globally? And I want to ask this because there was a great daily podcast recently about the Gates Foundation, who's done this incredible work to negotiate COVAX and really lead. And there's, you know, some complicated dynamics because the Gates have led with this technological innovation, and some of the partnerships and organizations they've helped build have also done this work. And they've, you know, brought they have a lot of power in WHO, and they've kind of shepherded some of the relationships with WHO, and they've actually told the WHO that we don't want you to lead this. This is our jam. This is what we want to lead and do. And there's some equity issues with that, is whose voices matter. What are we leading? What are we doing? And then those are questions about who gets the vaccine and why. I mean, and Rebecca, please, and Michael, please tell me if I'm wrong, or everyone, if I think it's 2 million vaccines have been deployed, or is it 1 billion, or is the goal? But a lot.
You mean to date under COVAX?
What is the goal? Yeah, what is the goal? It was a really big number.
So the original, the original goal of COVAX was to vaccinate 20% of the eligible population. And I think there is an effort to rethink and try to think about an ambition that would move to 2/3 of the world's population of eligible population.
Which is amazing and so exciting. So, but my question for you is, first of all, what does this do for global health? It's like the AIDS epidemic. Our innovation and possibilities and reimagining what is possible is, you know, new territory in these ways. And at the same time, there's a really profound resistance to releasing patents. So what does cost mean? What does profit mean? And what does equity mean? I'd love for you guys to kind of engage with these topics. And Rebecca, I know if you're wearing your Georgetown hat exclusively in this conversation. Not to jump in with a big one, but I think we need a moment on this.
Well, I'll start if no one wants to jump in. I mean, I think it presents a wonderful opportunity. I think to do something that is so both focused on equity, and I think that's really the wonderful part of COVAX. I think aside from their logistical challenge and achievement, just to have as a core principle or core value to be about justice and equity, I think is really important. I'm not convinced it's a test that the global community is going to pass, but I think it has the potential to really become the greatest example of, you know, sort of North-South collaboration and global achievement. So I think for that alone, it will serve as kind of a measuring stick of where we are. As Rebecca knows, you know, there's no such thing as a sort of a local pandemic, right? I mean, I think that anything that happens in any part of the world, we've seen time and again about every 2 to 3 years over the last couple decades, that these things have their way of making it around the world. And so I think we should use that as our incentive to actually demonstrate that we can create a framework that provides for the distribution of vaccine. In this case, it's vaccine. 5 years from now, it may be a medication that's needed. But I think this is a huge opportunity, and it would be a terrible thing to waste it.
I agree. I think that I think it's an incredible opportunity right now. I hate that we're in this position, but instead of turning crisis into tragedy, let's turn crisis into opportunity. And I think that I have maybe a little more faith in COVAX and in Gavi and in the ability to come together to produce enough product, but not just a product. It's about, there's vaccine and then there's vaccination. And so how do we get product into arms in every corner of the world? What does that mean from a logistical lift? What does that mean for cold chain? What does it mean for building these long-term sustainable systems that are able to deliver vaccine and other medical countermeasures to their entire populations? So I think that it is a challenge, and there is ambition, but I am really confident and feeling pretty good about how we get there. Now, it doesn't mean it's going to be easy, and there are lots of challenges that are coming up every day, and questions about liability. And Emily, to your point, there's questions about IP as we think about how we actually build and sustain manufacturing capacity around the world and supply chain, and the conversations that are being had between voluntary tech transfer and TRIPS waivers and building mRNA capacity around the world because of the platform that could be used holds so much promise. I mean, I think there's a lot happening right now. It's a really busy time in thinking about what this global architecture could and should look like. At the same time that we are literally moving product around the world as we speak.
Thank you. I agree. It's an incredible effort. It's an incredible feat. It's an incredible accomplishment. And so, we'll see what happens and see how everything lays out. I want to actually ask specific questions about vaccine uptake in New York City and also in Reading. So Mayan, can you talk a little bit about vaccine distribution in New York City and what that looks like?
Sure, yeah. It's interesting. I think in a lot of ways, New York City is a microcosm of what plays out globally in so many ways. And with vaccines and thinking about vaccine access and equity, it's no different. So something that we sit with a lot in our vaccine rollout program is really thinking about the legacy of medical racism, of course, not unique to New York City, but part and parcel with global health history, and thinking about this operation as not just a vaccine distribution operation, but really a trust earning endeavor. And so some of the ways that work looks is taking the time to create safe spaces in partnership with trusted community-based organizations or other groups where people can talk to a doctor or health educator who looks like them, who speaks their language, and who can answer their questions about the vaccine and who can do some of that myth busting. I think one really big challenge and kind of inherent tension is this pull towards vaccine speed and vaccination speed, and this pull towards equity. And sometimes those two are not always pulling in the same direction. And something that we saw really in the early days of the vaccine rollout in New York City, in the very early days, was that the people who were able to kind of elbow their way to the front of the line and spend their time kind of refreshing vaccine scheduling websites and put in all the research and legwork to find where they could get their vaccine through their networks and various forms of power that they had, it led to a lot of disparities in who was getting vaccinated, and many more disproportionately white people and people with more privilege were able to get those vaccines first. So I think our work is really cut out for us in figuring out creative ways to not only plop a vaccine distribution site somewhere in an underserved neighborhood, but really taking the time to make sure it's something people are aware of, that they've had their questions answered, that they know it's coming, that it's in partnership with a service provider organization that they really trust, and also that there are appointments for vaccines that are specifically reserved for the most marginalized populations. In New York City, people love to rush to get to things quickly. That's what we do. So it's been really important to kind of start this process of dedicating, carving out vaccine appointments specifically for different demographic groups that have been really historically neglected and marginalized, so that they kind of have a first shot, so to speak, at getting the vaccine whenever they feel ready.
Wonderful. And Maida, would you provide a little bit of information? I know you've been studying vaccine hesitancy a little bit in Reading, and have some information about how people are perceiving and responding to vaccines available.
Yeah, of course. First, I just really want to emphasize what Mayan said about having basically taking the time to educate people, as well as something that's not necessarily as relevant in Reading, but the history of medical racism and medical apartheid, which has dramatically affected how Black and Brown communities view government initiatives on health. In Reading, the story is a little bit different. It's majority white, so that changes the history, but there is a really large tendency to mistrust medicine and vaccines in particular. We actually have a very, very large anti-vaxxer community. At my state rep, or yes, my congressman to federal Congress is an anti-vaxxer openly. And there are many other officials who are as well. And that, of course, has influenced in Reading. A lot of people were not willing to get the vaccine. I think when they were first rolled out, one of our local hospitals, almost 2/3 of medical staff at the hospital were not ready to take the vaccine. And that was a combination. Maybe some of them had explicitly anti-vaxxer sentiments and others were afraid. I think it's been really helpful to see, for people to see other people who got the vaccine and are doing okay. So I know a lot of people who were nervous about it and they just wanted someone else to go first. And once they saw their friends that were okay, and just having people update them on that, a lot more people have been more likely to go and get a vaccine themselves. But it's still, I think it's a very different situation because of this kind of anti-science, anti-medicine attitude in Reading. But I think there are a lot of similar principles can be drawn from New York City and from Reading too. Basically, making sure to take the time that people trust you and talk to them personally. Reassuring them along the way, giving updates on what's happening. And even in Reading, where there isn't that much demand for it, there's been a huge problem in distribution of vaccines, which has made things 10 times harder. So even the people I know who do want to get a vaccine, they aren't able to access it and they don't know how. A lot of it is informal. They'll go run to the hospital because they got a call. Like I knew someone at a hospital who said that they had several vaccines were going to expire that day. So I gave a call to all of my friends I knew and I said, go run over to the hospital and go pick it up then. So that's, I think, what Mayan was talking about a lot. People who, whether because of the chance of the moment or whether they're intentionally trying to move their way forward, like a lot of celebrities who don't necessarily qualify as frontline workers who have gotten the vaccine very early as well. But I think that breakdown in distribution has just led to a lot of problems all around. And it's fomented a lot of mistrust, because then people see a sense of corruption in the government about who's getting it first and who's still waiting.
That's really wonderful. One thing that I'll add, I've been doing this ethnography in rural Iowa for a year. The two things, so Iowa's been kind of written about as the worst place to be for the pandemic because their governor has done almost nothing. They never shut down. They had a mask mandate for a minute in November, and they took it away right before Super Bowl Sunday. I mean, everything's been very political. But the two things they've done really well are testing and vaccine distribution. And it kind of reflects this other thing. For me, it's a microcosm of what the US does well with health interventions. We do well with technology, but we don't always do well with social and political framing and responses. So, this book that I'm working on is called Shame. And part of the reason why is because when federal policy failed to act, when state policy failed to act, and local public health officials had no power to do anything, the only thing people could do to influence behavior was shame others. And this is what happened. And largely the business community took hold of the reins and determined the outcome of the pandemic and how people would behave. Which was a really powerful thing to observe, and it's been a powerful thing to reflect on and look at, and it reinforces the need for states to act, for federal actions. I wanted to bring it back to a question that I think all of you can kind of talk about. Rebecca's worked with mayors on pandemic preparedness for a really long time, but we keep coming back to the fact that we had very little federal response. Some states responded strongly and others didn't, but the local was really the kind of focus of the pandemic. And like Rebecca does, she, nailed it years before. She knew it was coming. She knew what we needed to do to prepare. But what does the local do when the local that needs to act is politics and public health officials have so little power to do anything except message? That's been pretty powerful finding for me. Rebecca, do you want to provide some?
I mean, I'll jump in really quickly, and then I will apologize. I'm going to have to go in a moment. But public health actually has a tremendous amount of authority, and I think New York City definitely does, right? Like there's a lot of public health laws on the books. The public health community has been very reticent to use those authorities for most of history. We are, and there's lots of reasons for that, right? And a lot of it comes down to Emily, the work that you do and studying behavior and what incentives work and what doesn't, and how populations work together. And I think that it was, I think there's actually a lot of power in public health, maybe in the future. I mean, I think one of the things that's happened this year is that the general public has now realized just how much power the public health community could have, that public health can curtail your freedoms. And one of the things that we've been doing in our research center is actually tracking all of the policies, but also the legal authorities for doing so, and all of the court challenges and the several hundred court challenges that are currently underway domestically and then also around the world. And so it's going to be a really, it's going to be a busy year to 2 years to 4 years as the domestic community and the global community really kind of looks at and figures out what's the right balance of power.
That's so insightful. Thank you, Rebecca. And I know you have to go. We're really grateful that you squeezed us in and spent an hour with us. So thank you so much. And thanks for all your service. Maybe we can ask the next question to Michael. So how do you assess the possibility of the current COVID pandemic fostering a higher degree of international collaboration in public health, such as research policy and development? I know we talked a little bit about this, but what do you see or imagine is possible for future steps?
Well, so as I think we discussed briefly a few minutes ago, I think it creates a huge opportunity to rethink the way we do a lot of our international collaborative research. And I think that the model of, or the lessons learned from COVID-19, I think can help inform those types of policies. One of the challenges, for example, the World Health Organization, is that they really don't have a lot of resources to put into research or to put into training. And as a result, it's left, I think, to a piecemeal approach for developing these kinds of networks. And so I think it really is going to fall to, frankly, to wealthy countries to acknowledge that their health very much depends on the health of poor countries. And the better job we can do at building disease detection and surveillance and security infrastructures in those countries, the benefits of that are not just the obvious and immediate, which is, those diseases don't impact, wealthy countries. There's a longer term sort of tail to that, which is that you tend to basically elevate the overall quality of public health performance in these countries. And so for those who, like myself, who care about things like the Sustainable Development Goals and monitoring metrics of, health, you will likely see that an improved public health infrastructure system, even if it's built to deal with pandemic surveillance, is going to have collateral benefits. We saw that with PEPFAR, right? So PEPFAR was basically an AIDS program. But in fact, if you look around PEPFAR, or if you look in countries where PEPFAR was prominent, you also began to see a lot of sort of collateral improvements in public health infrastructure and in other aspects of healthcare delivery. So I think it presents that kind of opportunity. It's going to be a challenge if we can actually achieve the level of cooperation needed. But it has a huge benefit to lift people out of poverty and to generally improve health in most parts of the world.
Great, thank you. We have a question from Sarah that I'm going to bring to Mayan. So as vaccines reach populations, are vaccine record databases syncing with COVID testing results, particularly for variants? Essentially, are our communities able to track if vaccinated members of a population come up for, positive for a variant later? And I have to add that Mayan is a data guru, so this is and a tech guru, so this is right up her alley.
I don't know if I'd go so far as guru, but I do know a little bit about this. So New York City is kind of unique in that we have this thing called the CIR. I think it stands for Citywide Immunization Registry. And basically, like, since I was a baby born in New York, every vaccine that I've ever gotten and everybody else's vaccines are in this kind of one registry. And that's really amazing. It's a massive undertaking to maintain this database, and I'm not sure the extent to which that's possible in other settings. But what's really interesting about what we're doing here is that we're actually working on an integration between that database and our contact tracer program, so that when somebody contacts someone who's been exposed, they can see their vaccination status and they can make an appropriate recommendation about quarantine accordingly. And that's pretty exciting. It's new, it's still kind of in the works. And I think, using the CIR in creative ways within the bounds of respecting privacy is going to be an interesting conversation in the months and years to come. The other piece of the question in terms of variant detection, this, as you all know, this is all happening so fast. So New York City has really rapidly kind of ramped up our surveillance kind of labs that are focused on sequencing different variants in order to have a better sense of what variants are circulating around. And I think, whether it's possible to have every single COVID test sample be sequenced for DNA is unclear. I'm not sure if or when that would ever happen, but some of the conversations going on right now are figuring out what kinds of sampling can happen with those samples. So how many COVID test result samples should be sequenced, and how do we kind of make our policy decisions around that? So these are really interesting questions. I can't say that I have answers just yet, but it's a rapidly evolving space for sure.
And one more question for Maida. I know this is something Maida and I talked about quite a bit, and I had got a private chat about this. But what is the role of medical racism in vaccine hesitancy that we're seeing right now in the US? And I know all of you can probably talk to this. There's different kinds of vaccine hesitancy, and this one in particular has been affecting people's decisions to get vaccinated. what can the public health experts do to ensure that the COVID-19 vaccine is safe and not targeted with ill intent towards communities of color is the question. And I'd say that they aren't being framed in that way, but I do know that, you know, with the long kind of standing fear, mistrust, rightfully so, of many communities of color, there's a lot of hesitancy. Nada, do you want to share some of the things we've been talking about?
I'm sorry, can you repeat the question? There was just a lot to take in just now.
No, I kind of read the second half of the question, which is this assumption that there is indeed unsafe practices or targeting of communities of color, which a lot of people do feel they have. The question is really about what is being done with communities of color to address the real problems in America of medical racism and how people are thinking about that vaccine and feeling safe and secure and cared for seeking it.
Yeah. I remember something that really struck me. I used to work at our county public health too. So I was talking with them about what they were doing for, we have a pretty large migrant Latino population and also for Black populations in Reading. And their goal was, we're going to distribute vaccines to them first, which I'm sure some of you can anticipate the problems with that, which was that there's been, with Henrietta Lacks, with the Tuskegee syphilis experiments, there's been a really long history of using Black and brown populations as the first population to test uncertain medical treatments on. So I think a lot of Black and brown people in Reading, for example, felt that instead of them being prioritized for the vaccine, they were used as a testing population. And I'm sorry, my mind is going in so many different directions. I think with that, one of the important things is, and one of the simplest solutions is have a Black and brown person in charge of vaccine distribution. Something I've learned in my global health studies and also being a brown person in mostly white spaces my whole life, there are a lot of things you can't learn through your academic education. You have to live through some experiences and you have to know that community personally. And I think it is really important, not to say that there should be any kind of identity politics, but to say that you should have a genuine understanding of that community when you're making those decisions, because otherwise things like what happened with the vaccine rollout for prioritizing Black and brown communities did backfire. Another thing this kind of reminded me of is I've seen a lot in the medical community lately. Practitioners are trying to address general medical racism, for example, the way that Black mothers are treated. I remember listening to some really horrifying cases about Black people who went to the ER with COVID and were turned away and later died from it because their pain is not taken seriously. I know JAMA recently published a pretty infamous podcast at this point about trying to address structural racism that turned out very poorly. And now they were once again trying to address it with another podcast where they seek to clarify things. But I think, again, it goes down to the same thing. It isn't just vaccine distribution, it's this whole system. Even the way Professor Menhong, you and I have talked a lot about this, the way that people with other chronic conditions or with obesity are treated in the medical care system means that a lot of the times it's not necessarily their actual condition that will predispose them to certain complications. It's the way that they're treated by practitioners. So I think there needs to be a really big overhaul of the way doctors and other clinicians interact with their patients, and it needs to go beyond simply talking about anti-racism initiatives or those kind of educational neat little workshops that they'll have. It really needs to be a deeper understanding of how dramatically how the entire medical system has damaged these communities from day one, and especially in global health where so much of these initiatives were created to save white people from tropical diseases rather than addressing health issues on the ground. Sorry, that was a little bit long, but
it was excellent. And Michael, from the medical school side and Mayan from the New York City side, do you guys want to provide some more insight as we have 5 minutes. So it'd be great to hear from both of you before we conclude today.
Mayan, go ahead.
Sure. I think Maida really hit it. Is it Maida or Maida? Am I saying it right?
It's Maida, but you can call me.
Maida. I also have a different sounding M name, so I want to get it right. Yeah, I think you hit the nail on the head. This is so much bigger than just a question of vaccine distribution. This is really about how systems serve to either protect or harm Black, Indigenous, and people of color. And I think, a lot of my own work outside and pre-COVID has been related to maternal health and how Black women are treated within healthcare systems. And the truth is that these are the very same healthcare systems that are trying to distribute vaccines to people. And to not make space to recognize that ongoing history is a huge mistake. So without going into too much detail about some of the programs I've talked about, I think the biggest takeaway for me in our work is the kind of the partnerships and the conversations and the listening that has to happen on the ground before you can show up and just start vaccinating people. Of course, supply is part of that conversation and making sure there's an allocation of doses to people who are in marginalized and underserved areas. But most importantly, it's about making space to earn trust and to really transform the way we think about our health systems as places where there are quote unquote mistrustful patients, and transform them into places that are really oriented around earning that trust. And I can share just a couple of lighthearted stories because this is a heavy topic that I think keeps many of us up at night. But, in our work, sometimes this looks like really creative stuff where we are partnering with old school reggae record labels and radio stations to bring conversations and live Q&A about what vaccines are and how they work in the body, mixed in with music that people want to hear and want to listen to in a way that feels joyful and feels relevant and feels rooted in ways that people want to get their information from people that they trust. And I think the very last thing I'll say about this is I was in a conversation yesterday with an organization who works with domestic workers who are largely Black and brown women who have been just at really the bottom of the list in terms of getting access to COVID-related care and resources and protection. And what came out of that conversation is that many of these women feel that those who have survived this illness have done so through the ability to use natural remedies, to ride it out at home, to draw and tap into their strength and their prayer, and all of these kind of different ways of coping. And I think it's really important when we come in, raring to go with needles to put in people's arms, to recognize all the different ways that people have been coping and the strength that they've had to make it through to this point in history that we're at, and just kind of acknowledging that and making a space to say, we see you and we know what you've been through, and we're here when you're ready. So.
And Michael's going to add something quickly before I wrap up. So thank you.
Sure. I would just say very briefly that it's heartbreaking to see this level of sort of well-founded vaccine hesitancy in these populations, because I can tell you more than half of the children that I've taken care of in the intensive care unit with the most severe forms of COVID-19 and the MIS-C inflammatory disease, they are Black and brown kids. And so it's really kind of tragic that, or if we're not able to access them with vaccine, because those populations have clearly suffered disproportionately from the pandemic up to now.
Well, thank you all. This is a very serious topic, and we could talk for a number of hours more. And unfortunately, we cannot carry this on over hors d'oeuvres or dinner to talk through all of the questions that will come up with COVID, with vaccines, with really these core questions of equity and what we do when we innovate and we think about our places in this very complicated world. We appreciate the time that you have all taken to spend with STIA. It's really a privilege to share this virtual space. So please go well, be safe, get vaccinated, and hopefully we'll see you all soon. Thank you.
Thank you.
Thanks. Thanks, everyone.